Good morning. Today we have a operative scenario discussion on superficial parotidectomy. Dr. Omkar Nath, who is a third year DNB resident at Imar Hospital, will present. And with us today is Professor Utpal De, who is Professor of Surgery at NRS Medical College. So, Utpal, as you do in our exam scenario, it will be just a card of superficial parotidectomy. Omkar Nath is here.
Good morning, sir.
Good morning. Yeah, okay. Start.
Yeah, we can start with indications.
Okay, yeah. Tell me the indications of superficial parotidectomy.
The benign tumors of the parotid gland, like mixed parotid tumors, adenomyoma lymphoma, Warthin's tumor.
Apart from benign tumor, any other condition which may need superficial parotidectomy? There are some more indications.
There are more indications, huh?
Yeah. There is no other condition in parotid which are benign apart from tumors.
Other benign tumors.
Like benign tumors you have said. Apart from this, there are some conditions like.
Do you know about any inflammatory condition which requires superficial parotidectomy?
Yeah.
Any malignant tumors which might require superficial parotidectomy?
For benign condition, it's a chronic sialoidinitis. Okay. Yes. There are some conditions known as duct ectasia in the parotid also. If you have a stone in the parotid duct, although it is rare, but there may be stone in the parotid duct which is causing recurrent parotitis. And then some malignant tumors which are low-grade tumors confined to the superficial lobe. You can go with a superficial parotidectomy.
Okay, sir told about some low-grade malignancies, right? I think you have read about the anatomy of the parotid also. So, can you tell me any other tumors in the adjacent regions which might require superficial parotidectomy? Do you know about the lymphatics? Are lymph nodes present in the parotid? First, tell me.
Yes.
Where? Huh? Where?
So there's a pattern of distribution of lymph nodes in the parotid. So superficial lobe, it contains more than 90% of the lymph nodes. Deep lobe contains 10%. So tumors which are adjacent to the parotid, like some epithelial tumors, malignant melanomas, they tend to metastasize to the parotid. Okay. Now, for these tumors, suppose there is a deposit there, then you need to confirm, isn't it?
Yes.
So, if you want to confirm, there are certain ways of confirming. And one of these is superficial parotidectomy.
Right? And some people say that, what is the minimum biopsy in parotid gland?
Yeah.
Yes. It's not a two-cut biopsy. Okay.
So that means if you divide the indications, I think it is better to say that, yes, we do a superficial parotidectomy. The most common indication is the benign tumors like pleomorphic salivary adenoma, as you rightly said. We do it for some inflammatory conditions like sialoadenitis that we have said. You do it for some localized benign tumors. That has also been said.
Audio got off. Dr. D, your audio is not clear now. আবার রিজয়েন করবে? Oh, load shedding. Acha, acha, acha. Hey, Baba. That mobile is I mean, I'll just continue with the anatomy. Okay, there is some network issue, Dr. De. Okay, as Dr. De was asking you about the anatomy, because if you are to describe the operative steps, the anatomy parotid is very important. So, where is the parotid gland located?
Parotid gland located in the parotid region.
Okay, fine.
Bound-
So what is the boundary of the parotid region?
It is bounded above by the zygomatic arc, below by the
Zygomatic arch, and if
posterior
you
belly of
zygomatic follow laterally, it will be the external auditory canal.
external auditory canal. Below by the posterior belly of digastric
And the
फिर,
posteriorly?
posteriorly by masseter.
No. How can masseter come posteriorly? Posteriorly is
Mastoid.
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 Posteriorly by mastoid
And
anteriorly by the anterior border of the mandible.
posterior border
Posterior border
of ramus submandible. It is specifically said. Anteriorly by the posterior mandible, overlaid by the masseter muscle. Okay, so that is the parotid region. So if you now go into the further anatomy of the parotid gland is characterized by some anatomical delineation. What is that? It has got two lobes.
Yes, sir. Superficial and deep lobes divided by the faciovenous plane.
Faciovenous plane. Okay. Faciovenous plane consists of what?
Facial nerve and vein, retromandibular vein.
There is a plexus of vein, and then ultimately it forms a retromandibular vein. Okay. So facial nerve is important here. Okay. If you now come to the facial nerve anatomy, where does the facial nerve emerges from? From the base of the skull?
So emerges from the sternum-mastoid foramen.
Okay. So sternum-mastoid foramen posteriorly there is a bony landmark. What is that?
Styloid process.
Styloid process. So as the facial nerve emerges from the sternum-mastoid foramen, what happens to this nerve?
The facial nerve goes transversely or obliquely for 1 to 2 centimeters.
It gives a few branches.
Then it gives two branches, temporofacial and cervicofacial.
No. Before it gives a main two division, as it emerges sternum-mastoid foramen, it gives branches which supply the occipital belly, occipital frontalis. Okay.
Yes.
So after this, it divides into two main branches.
Temporofacial and cervicofacial.
Yeah.
Upper temporofacial giving zygomatic and temporal branch. And lower cervicofacial giving
Then another branch.
Buccal.
Yeah, upper buccal.
Upper buccal.
And
yes. And lower cervicofacial gives lower buccal, marginal mandibular and cervical.
Fine. So these are the ramification. And as it goes in the parotid gland, what happens to each of these branches? What is space answeriness? These branches have intercommunications. These branches have intercommunication, which are described as space answeriness. Okay. Then these all the branches emerges from the anterior border of the gland. What is the relation of the duct with the branches of this nerve? Because this is one of the guidelines that you search for the duct. As the duct emerges from the superficial lobe, so there are nerves in relation to this. What are those nerves?
Posterior auricular.
Great
auricular.
No. Great nerve is in the angle of mandible. I am talking of as the duct emerges from the superficial part of the gland, it runs over the masseter and then turn inward. So when you find the region of the duct, you find two nerves, one above, one below.
Yes, sir. Upper buccal and lower buccal.
So if you can trace the upper buccal and lower buccal nerve, you can find the duct going in between the two. Yes. Because you need to search for the duct while doing a superficial parotidectomy. Fine. So as you know the indication. Yeah. So I was asking the anatomy. I asked him the distribution of facial nerve and space answeriness. So now I think we can pass on to the steps.
Just one point regarding, I'll like to ask, sir was telling about the buccal nerves, right? So in relation to the buccal nerves, can you tell me what is Zucker's point? Zucker's point, Z-U-K-E-R-S, Zucker's
No, no.
point. See, sir was telling about the means branches of the facial nerve. So three branches actually they have constant position, right? One is the temporal branch, the buccal branch, and the marginal mandibular branch. So when we if you look at the different types of parotidectomies, then you will find that these three nerves are constant, and when we try to do it in a retrograde manner, then we can trace these nerves and do a parotidectomy. Zucker's point actually is if you draw an imaginary line from the tragus to the angle of the mouth, right? The midpoint between that in that line is what is Zucker's point. So that is a constant point. Okay. So I actually saw when I was taking an exam, one examiner asked this question. So I just recollected it. So that is also important.
So this will correspond to the duct or to the buccal branch?
Buccal branch.
Yeah.
The duct actually runs parallel to the buccal branch.
Yeah, in between the upper and lower buccal.
Yeah, exactly. Okay. So now you have told me about the indications, right? So can you tell me the different types of parotidectomies before we proceed on to superficial parotidectomy?
Superficial parotidectomy, total
No,
conservative. Total
Yes.
conservative parotidectomy, radical parotidectomy,
Okay.
extended radical parotidectomy.
Okay. What is extracapsular parotidectomy? What is the meaning of all these? Means superficial parotidectomy, total parotidectomy. Okay, then extended radical parotidectomy, what we have said, extracapsular parotidectomy.
So, superficial parotidectomy means removal of the superficial lobe of the gland above the faciovenous plane. Total conservative parotidectomy means removal of the superficial as well as the deep lobe of the gland.
Is superficial parotidectomy anything to do with faciovenous plane? Is it a constant plane or a virtual plane?
Constant planes.
No, it's a virtual plane. It is not, it cannot, means people say that the superficial and the deep lobes are connected by an isthmus in which the facial nerve actually lies, but it is very difficult, means there is no anatomical boundary definite boundary between the superficial lobe and the deep lobe.
Yeah, it's just
a virtual plane.
Neurovascular plane.
Yeah. So we remove the superficial lobe in superficial parotidectomy, right? What do you do in total parotidectomy?
So we remove both the superficial and deep lobe of the parotid gland, but preserving the facial nerve.
Yes, very good. So our point of discussion regarding parotidectomy is all related to the facial nerve. So whether we preserve it or we destroy it. Okay. So in superficial parotidectomy and in total parotidectomy, we try to preserve the facial nerve. And what about radical parotidectomy?
So we have to sacrifice facial nerve along with the buccinator.
Buccinator do we divide in total parotidectomy?
No, sir.
So in total parotidectomy, we remove the means radical parotidectomy. In total parotidectomy, remove the parotid gland, keep the facial nerve.
Yes.
In radical parotidectomy, we remove the entire parotid along with the facial nerve.
And the adjacent lymph node. And the adjacent lymph nodes.
Yeah. And then if you come to more extended, what you say, radical parotidectomy, then it includes many things. It might include removal of
the adjacent structures.
Depending on what structures are involved, along with a neck dissection also sometimes it's involved. And what is extracapsular parotidectomy? Have you heard about it?
Yes.
And what is it? See, this was one of the terminologies which was used previously. It's no more used now, right? So there was a notion that sometimes there are cysts in the parotid gland. So what we do, we remove the cyst. We do not go or try to find out the facial. So that is what is extracapsular parotid. But it is no more in vogue, but sometimes examiners are fancy to ask this sort of questions, right? Okay. Now tell me the approaches of the parotid. Then we will come to superficial parotidectomy. How can we approach the parotid gland? You have seen parotidectomy, na?
Yes.
So what have you seen there?
Sir, we have to first give the incision and try to we have to dissect the skin flap and
That is
and then-
regarding the operation. Tell me the approach. Like in cholecystectomy, we have a fundus first approach. We have a retrograde approach. So these are the different approaches, right?
yes.
So if I ask you, how do you approach a parotid gland? Then how do you say that? So it can be antegrade, it can be retrograde,
Yes.
right? So these are in relation to the facial nerve because
Yes,
that is the most important thing in a parotid dissection. And the other one is if you try to go through the parapharyngeal space, means if you go cut the stylomandibular ligament and approach the gland from behind, means from the medial aspect. So that is more in relation to involvement when there is involvement of the deep lobe. So these are the main three approaches. That is, if you go to the parapharyngeal space, then it becomes much more difficult, right? So we usually do not do that. There are chances of injury to the facial nerve, but then when the deep lobe is involved, then we have a parapharyngeal approach. But the common approaches are mainly an antegrade approach and a retrograde approach.
What are the two? Antegrade means what?
So antegrade means we have to trace the trunk of the facial nerve and then trace for the
So the
branches of the
branches.
facial nerves.
Sometimes it is difficult. You cannot go. In that case, you go to the anterior border of the parotid gland.
Correct.
Find the branches and then go retrogradely to the trunk.
Trunk.
Now, sir was telling about in the indications in superficial parotidectomy, we do a superficial parotidectomy for salloadenitis also. Is there any difference between performance of superficial parotidectomy in salloadenitis and in other diseases, for other diseases? What extra precaution do we need to take? Salloadenitis are what? These are stones, isn't it? So stones may be present in the gland, in the duct also. So we must be
Yes,
extra
yes.
cautious to trace the duct right up to the opening. Because if we do not trace the duct and remove the duct, then sometimes what can happen is we can miss some stones. And some stones may remain behind, which might cause problems later on. Okay. So the difference is here we need to trace the duct right up to its opening, means where it crosses the masseter and then pierces the buccinator, right up to the point where it opens into the mouth in the upper jaw near the second molar, right? So we need to trace right up to that point. Okay, so these are about the these are some points in anatomy, means which you need to remember, because superficial parotidectomy is mostly related to anatomy, right? Okay, now tell me the procedure.
First,
Describe the steps.
starting with the anesthesia, we have to give general anesthesia with endotracheal intubation.
Can we do it under local anesthesia?
No, sir.
Yeah, some books have described, but yes, you say we do not do it under local anesthesia. It is very difficult, right? But there are references of people doing superficial parotidectomy under local anesthesia also. Okay, then would you like to do an nasotracheal intubation or an usual endotracheal intubation?
Endotracheal intubation.
Huh?
Endotracheal intubation.
Sir,
when-
nasotracheal or orotracheal?
Sorry.
Which one,
Orotracheal.
orotracheal or nasotracheal?
Orotracheal.
When do we do nasotracheal intubation? Because sometimes when the deep lobe is involved, it is very difficult to put in a tube through the orotracheal route. So there we perform a nasotracheal intubation. Otherwise, an orotracheal intubation is sufficient. Okay, then
Yeah. Position and dripping.
Yes. Then position, sir. Then we have to extend the neck by placing sandbag under the shoulder and
shoulder. Okay, ठीक है, shoulder, then
and
These are very
and
important
we have
things.
to
Head should rest on
yes, head should be rest on
head ring.
head ring,
Yes.
and we have to
And-
move the head to the opposite side, and it should be elevated up to the 15 degrees
Why?
to reduce the venous congestion.
Okay, very good. So to reduce the venous congestion, we need to extend the neck and then turn it to the opposite side. Okay, done.
Then after antiseptic cleaning and draping,
What draping?
Yeah.
What draping? What is the specialty of draping in the head neck area?
we have to drape till the neck.
This is again
What-
like thyroid.
what-
It should be a 3-towel dripping.
Sit down.
You put one Macintosh, 2 towels below the head, turn it around. And then do you need a meostable to be kept on the chest side? देखा नहीं कभी?
What are the areas which need to be kept exposed during the draping and why?
So, from lateral border of the neck
To medially?
medially up to the up to the lateral margin of the nose.
That means
Lateral margin of the nose. What is the idea? Why did I ask this question? Tell me. Think about why, because whenever someone asks the question, there is some idea behind asking that question.
you need to trace the whole nerve branches over the mesentery as it emerges from the anterior border. So you have to almost expose up to the angle of mouth.
Exactly. Means when you are dealing with a facial nerve is so important, you need to see all the structures which are innervated by the facial nerve. So during surgery, you will be aware of what you are dealing with. So that is important. So that is the reason why you need to keep the outer canthus of the eye and the angle of the commissure of the mouth on the side in which you are operating, that should be visible. Then you find that all the muscles, because you need to see the twitchings, right? Okay, then
starting with the incision, we'll go for the Legius incision. And,
what is the name of that incision?
Modified Blair's incision.
Yes.
Modify. Okay. Describe that incision.
So starting from the zygomatic arc, extend below, below and in front of the tragus, then and then bending backward to reach the mastoid and extending below up to the skin crease of the neck.
Okay. What is the common deformity which can occur if you give a modified Blair incision? Do you know what is pixie ear or satire deformity? Have you heard of it?
Don't know.
Pixie ear or satire deformity is if you give a modified Blair incision like this, then what happens after the wound heals, then you find the ear being dragged down like this. So it gets attached to the incision and it gets dragged down. So that is known as pixie ear or satire deformity, right? And now to avoid that, can you give any other incision? Can you make any other incision? There is another incision which is known as modified face lift incision. Now, it is same as Blair incision, but then in modified Blair incision, what we do is we come anteriorly along the distal crease of the neck, isn't it? But here, instead of coming anteriorly, we go posteriorly and then along the posterior means occipital line, we go more distally and then we lift the whole skin down, right? So this is an alternative to modified Blair incision. Okay, so these are the two incisions that we usually make for a parotid gland, but standard incision is what you have said, that is modified Blair incision. Okay, then
we have to raise the skin flap.
How far you cut? As you cut through what?
Up to 1/3 of the sternum.
Skin, subcutaneous tissue.
Yes, sir.
As you come to the neck,
Sir,
platysma doesn't come in the preauricular region.
Platysma comes in the neck, isn't it? It
Neck.
does not go above the angle of the mandible.
So cut the skin subcutaneous tissue.
yes,
And then come to the neck, you have to cut out the platysma. So you have to raise a sharp platysmal flap in the neck and skin subcutaneous tissue. So as we start raising, how far you raise the skin flap?
above up to the zygomatic arc and anteriorly up to the anterior border of the parotid gland.
Only after anterior border.
What is the boundary of the parotid? Tell me the boundary. Because if you know
Yes,
the
sir,
boundary, you know how much you need to expose.
Yes. Boundary, sir, anteriorly by the posterior border of mandible.
Anteriorly by the posterior border of mandible. Where is your mandible?
Mandibular ramus.
Which muscle lies anteriorly?
Masseter.
So anteriorly it is the masseter muscle. Border of the masseter muscle. Superiorly?
Superiorly, sir, by zygomatic arc.
Very good. Inferiorly?
Inferiorly by the posterior belly of digastric muscle.
No. Inferiorly by the medial border of the sternocleidomastoid. And posteriorly?
Posteriorly by the
External auditory meatus.
mastoid.
Okay. So when sir asked, you need to raise a flap so that all these boundaries are clearly visible. Sir asked you raise a subplatysmal flap. Why? What is the reason of raising a subplatysmal? I can go in between the skin and the platysma also and raise a flap.
What nerve supplies the platysma in the neck?
Facial.
Which branch?
Mandibular branch.
Mandibular branch. That supplies the angle of mouth, oral muscles. That is supplied by cervical branch. Yes.
So you need to preserve that, isn't it? And also you need to preserve the marginal mandibular, which usually supplies the angle of the mouth. Okay. Okay. Then you raise a flap. So flap should be a bit thick. Huh? Okay.
Yes. Then we have to dissect the posterior border of the parotid gland.
Do you encounter anything there in the posterior border?
Yes, sir.
What?
External jugular vein and posterior auricular nerve.
The external jugular vein is deeper, isn't it?
Yes.
It is very deep. I mean, superficial to that, do you encounter any nerve?
Posterior auricular, great auricular nerve.
Great.
Yes, great auricular nerve. Do you sacrifice it or you keep it, preserve it?
Sir, if dissection, if it comes in the path, then we can sacrifice it, sir.
Means if you look at, do you know the direction means in which direction it comes? It follows actually the external jugular vein, right? And then at the lower pole of the parotid, it divides into anterior and posterior branches. So anterior branch, in any case, you need to divide. Posterior branch, you can save. Okay, but sometimes you need to divide both the greater anterior and the posterior. Now, what is the trick? Has this nerve got any importance?
Sorry.
What is the supply? Motor or sensory?
Sir, sensory.
Where does it supply specifically?
Face.
Whole face it does not supply. It supplies the area near the angle of mandible.
Angle of them. I was actually telling why this nerve is important is because where do you need to, if you need to cut the nerve, where do you cut the nerve? Proximally or distally? You need to cut the nerve more distally, right? So that you can preserve that nerve so that if by chance there is injury to the facial nerve, you can use that part of the nerve as a cable graft. Okay. So that is the reason that nerve is important. Means, I mean, these are all of theoretical importance, but I don't, but still you need to know because these are certain important things where you need to, means if the nerve is injured, how do you repair it? So one of the ways in which you can do it is by using the greater auricular nerve. Okay, then proceed then.
Mm. Then, sir, we have to dissect, ligate, and divide the external jugular vein. And we have.
Why do you need to dissect, ligate, and divide the external jugular vein?
Sir, it will
External
make the
jugular vein
field.
is deeper.
Yes.
It does not come much in the way of the parotid. What comes in the way of the parotid is retromandibular vein. You're doing a superficial parotidectomy, na?
Yes.
So
Now
first
you
step
have to take entry between the posterior parotid gland and the
Anterior.
posterior digestic. How do you enter into this space? What
We have-
structure is there now?
We have to retract.
We have to incise something.
We have to incise the fascia.
What fascia?
Temporoparotid fascia.
What fascia comes from the sternomastoid and then split to enclose the parotid?
Investing layer of deep cervical
Yes.
fascia.
or it is also known as parotidomesenteric fascia. It is there are two fascias actually. Fascia which lies above this fascia, which is known as SMAS, right? And we have another fascia which lies deep, which is tougher, which you rightly pointed out, that is the parotidomesenteric fascia. So once you divide, then you find the what? Tail of the parotid. The tail of the parotid abuts what? Which muscle? Posteriorly, sternocleidomastoid. So you need to erase the posterior tail of the parotid from the sternocleidomastoid, and once you do that, then the posterior belly of digastric comes into view. Okay, now the real operations begins. So now what will you do?
Then we have to.
Next step is identify the facial nerve
Facial
trunk. Tell us how do you reach?
For that, we have to incise the parotidomesenteric fascia, and then we have to retract the parotid gland medially.
Yes.
And we have to go for deep dissection. And then we will come at the point the junction of the cartilaginous and bony part of the external auditory canal.
That is one guide.
Yes, sir.
Find the junction of cartilaginous and bony external auditory. What else?
Yes, sir. Facial nerve is 1 centimeter deep to this junction.
That is one point. Another,
Yes.
there are some
And-
more
yes,
guidance that you reach that area.
Yes, sir. Styloid process. Facial nerve will be medial to the styloid process arising.
Styloid process is deep, isn't it?
Yes, sir.
So
Styloid
tell us
process is
more
quite deep.
superficial structures. Like let us suppose you said that you would look for the junction of the cartilaginous point and the bony point, right? Suppose while doing dissection, it is a cartilage, it can break easily, isn't it? Suppose it breaks. Then how will you? Styloid process is much deeper. If you try to now find the styloid process, I am sure 100% sure you will injure the facial. Are there any easier way of detecting?
As you follow the posterior digestic, where does it end? Where does it get attachment? Posteriorly? Mastoid.
Angle.
Anyway, it goes to the mastoid. So as you trace the digestic up, it is attached to the mastoid. Then, any guide from that point?
There will be sir, posterior auricular artery beside the beside the foramen through which the facial nerve will arise.
No, you need to see the posterior belly of digastric. Okay, you look at the upper border of the posterior belly of digastric. There you start dissecting. And because the posterior belly of digastric and sternocleidomastoid, they get inserted into the tip of the mastoid process. So if you just go above the posterior belly of digastric and dissect that area, then you will find the facial nerve, which will lie at least
Medial.
30
Medial.
degrees, they say. Means some books they say 30 degrees, some say it is 0.8 millimeter, just deep to the sternocleidomastoid. But while doing, what we find is if we dissect that area, then the nerve is easily visible. Okay.
So it is quite deep. You have to understand that. Sometimes you feel some strand is coming up, but these are all superficial strands. Facial nerve is quite deep at that point.
Okay. What are the other ways? So you said about styloid process. You mentioned about the trigal point. Trigal point, did you mention? Huh?
It will be, sir, inferomedial to the tragal points.
Okay. Okay. You mentioned about the styloid process. What are the other landmarks? You have said already previously. The retromandibular vein. So that is also a landmark, right? Then you have the tip of the mastoid. So that is also a landmark. Any other landmarks apart from the normal anatomical landmarks? Can you take help of anything else? Apart from the
Now people are
normal
using.
anatomical landmark.
People are using in the theater.
We can also go for, sir, retrograde.
No. Any other
Many.
gadget you can use in the theater to identify the nerve?
Sir, nerve stimulator.
Nerve stimulator. Okay, while suppose you are using a nerve stimulator, would you like to tell the anesthetist anything before using the nerve stimulator? Or you simply use the nerve stimulator?
If the anesthetist gives the usual dose of muscle relaxant, can you find the twitch?
Yes.
No. So you have to ask the patient, anesthetist to not to give further muscle relaxant.
So it means what you do is while you are using that nerve stimulator, you have to tell the anesthetist that you please do not give muscle relaxants, because if you give muscle relaxants, then what will happen is the twitching that we usually look for, that you cannot see. Okay, so you need to tell the anesthetist, and you need to also alert your assistant to have a look. Okay, so that is also one feature. But see, if you look at all these landmarks, these are all temporary landmarks. So if I ask you, what is the gold standard landmark, then what will you say? This is an MCQ question, right? For NEET SS.
Only the point, sir, with junction of the
No, it is the tympanomastoid suture, because that is the only constant, means you cannot see it, you need to palpate it. So they say that the facial nerves lies 4.9 millimeter. That is also I don't know, means that was actually proposed by Shah et al. I thought, Makunda, you had done this study.
No.
I saw it, but then I found that no, it was proposed by some Shah. I could not get the exact
Shishi
reference.
Shah. Shishi
Oh,
Shah
acha,
from
acha,
UK.
Okay. So he said, means that is a question which was given last year in the NEET SS exams. So then that is a constant landmark, and they say that that is the gold standard landmark, right? Okay. So now you have localized the facial nerve. So now what will you do?
This facial nerve will go transversely or obliquely for 1 to 2 centimeter, then divide then divide into temporofacial and cervicofacial, and also give branch to the occipital.
Okay, fine. How do you proceed with the division of the gland now? You have the trunk in front of you, you have the superficial lobe, superficial to that, and deep lobe is lying deep to these branches. How do you now keep on dividing the gland?
Yes. Then we have to dissect the branches of the facial nerve. We have to take
how
one
will you
hemostat.
dissect? How will you dissect?
Yes. We have to take one hemostat and place it inside.
What kind of hemostat?
Artery forceps.
Oh, artery forceps, okay. Means will you take a long artery forceps? Will you take a mosquito forceps? What?
Mosquito forceps.
Yes. No, don't take a large artery forceps. You take a mosquito forceps. Okay, then?
Then we keep the bending banded portion of the
Now,
mosquito
will you place
forceps
the
are what?
hemostatic, will you place the mosquito forceps above the facial nerve or below the facial?
Below.
Below.
Between the parotid tissue and the fissure
the
and the nerve
Ah.
branch. And it
Okay.
keep on dividing the
Parotid tissues.
parotid.
How will you divide? With scissors, with monopolar, with bipolar?
Sir, with bipolar or with the scissors. Usually with the
bipolar?
bipolars.
Okay, with bipolar or these scissors. Okay, then
And we have to remove. We have to divide
you
all
see,
the.
there is a good proverb when we say bipolar. These are good servants but bad masters, right? They say. And people say that while you are dissecting the facial nerve, your assistant is very important, crucial, because while you are dissecting, your assistant should keep a look at the angle of the mouth and the external canthus of the eyes, which you have kept away, means which you have kept exposed. So it is only your vision of the facial nerve that is much more important. Okay. Okay, then
we have to dissect all the superficial tissue of the parotid gland in between the branches, and
you injure one of the nerves, one of the
Yes,
branches you injure.
yes, sir.
Are you afraid, or do you feel that no, it's okay?
You have different branches.
Yes.
What are the branches which are more important? Suppose you injure the subrachial branch. Is it going to make a big mobility?
Marginal mandibular nerve.
That is one, which division of angle of mouth. What else?
Then
A buccal get injured, it supplies what?
sir, orbicularis oris, orbicularis oris.
And
Mm.
which supplies the vaccinator? Mandibular or facial?
Vaccinator, sir, mandibular.
Oh, that is the only
All
exception.
muscles of the face are supplied by the facial nerve except that one, which is supplied by the mandibular nerve. Okay. Oh, what I mean to say.
Vaccinator is supplied by facial only. All muscles
Ah.
are mastication supplied by mandibular.
Mandibular nerve, yeah.
And vaccinator helps in mastication. If the facial get injured, there will be paralysis of vaccinator will cause accumulation of fluid in the vestibule of the mouth. Okay.
Means we are more we give
And
more
the
importance to
eye closure is more important.
Yes.
yeah.
So if you injure the upper branches, it can cause difficulty in closing the eyes. So these are the few branches which are more important, need to be preserved.
We are more concerned with the nerves which maintain the symmetry of the face, number one. Okay, number two is what sir said, means eye closure. Because those are means real problems, right? And moreover, what sir discussed about pace answeriness, isn't it? And these, what is pace answeriness actually? Means these are nerve communicants. Means all those communicating branches are there. So even if we injure one or two minor branches, that won't make much of a difference. That is what I meant to say. Okay. Okay, then. Now that you have dissected all the branches, now what are you going to do?
We have to dissect and ligate the parotid duct over the anterior border of the masseter.
Is it always that we ligate the parotid duct? Or is it a mandatory feature, or is it a optional feature?
Not mandatory.
Yes.
Not mandatory, yeah. So if we find that we have removed the tumor along with enough of the parotid tissue, a cuff of parotid tissue, then we can jolly well preserve the stent sense duct.
Yes.
Right. Now, tell me, what will you do? Suppose while doing, you rupture the tumor. Then what will you do?
We will instill 3% normal saline to.
Then Then after 2 months, you will find the patient coming back with another tumor. So we need to take utmost
Total.
care so that there is no spillage. And why if there is spillage, don't apply saline, you suck away whatever is there. Because the more you apply saline, it gets disseminated. So there is chance of recurrence. Okay.
Yes.
Okay. Then
Then we will remove the superficial lobe.
now you have removed the superficial lobe. Okay. Well, now what will you do? Do you like to do anything else, or
We will place suction drain, sir.
okay, very good. So
And
before placing the suction, okay, you have placed the suction drain. Then
so then we will close the
so before closing the skin, do you need to do anything to prevent something? Otherwise, that will come in the
irrigation.
way of complications.
Irrigation with it.
No, I'm not asking about irrigation. There is some complication which can arise following superficial parotidectomy, which can be prevented by doing something after you have finished this operation. You can place a flap, right? A flap of the sternocleidomastoid muscle over the region to prevent what? Fraze syndrome.
Fraze syndrome.
Right. So, or you can put in, some people, they also put a layer of fat also over it so that that Fraze syndrome is obviated. Okay. So you have placed a drain and then you will close the incision. What kind of dressing would you like to apply? Normal dressing. Is there any special dressing which you would like to apply? Do you know what is jaw bra dressing? It is a dressing like you apply it over the head, forehead, and then along the this chin, comes down below the mandible, and then you have, for holding that, you apply another transverse band-like dressing here. So that gives compression also, and that holds the dressing also. Otherwise, normally what we do, we apply those micropores and everything, but that is very clumsy, and the hairline is there, so it does not hold that much. Okay. So now you have completed the operation. So then you write the post-op direction and go home, or would you like to do something? We are very happy that, yes, I have performed a nice operation. So put up the next case, or you would like to watch the patient?
Watch the patients.
What will you watch?
To look for any change in the facial expression.
Yes, so you must make it a point that after you finish the operation, you should watch the patient to see whether everything is symmetrical. So there, at that point of time, it does not finish in the operation table itself. Means while the patient is in the recovery room, you should go back and make it a point to see that everything is okay.
You have preserved all the nerve branches,
Yeah.
but still find that patient has some difficulty in closing eyes, angle of mouth is slightly deviated. What may be the reason?
Pressure over the face.
Pressure. What pressure?
Pressure.
You see, while dissecting, there may be some stretching. While dissecting, there may be some stretching of the nerve. So there may be some transient pulsing. That is because of traction, you apply diathermic adjacent. So if you are confident that you have preserved all the branches, you assume that this might be a temporary pulsing, which might clear off.
Okay. So now you have completed, patient has gone back, right? Now tell me some complications of this surgery.
Yes, sir. It could be, sir, hemorrhage.
Hemorrhage.
Yes.
Okay.
Hematoma.
Hemorrhage, I think, means when you are closing, it's a superficial operation. So you have done a meticulous hemostasis. Yes, there can be hemorrhage, but then that would lead to what? It can come out through the drain or it can lead to a hematoma formation. Okay, then?
Sir, infection, facial nerve
In-
injury,
Before
So
infection, talk
facial,
of facial nerve also.
facial nerve.
Okay.
so facial nerve palsy can be there. There can be surgical site infection. There can be a hematoma formation.
Yes.
Okay, then
Sir,
tell me the important ones.
parotid fistula,
Yeah.
Frayed syndrome, development of the Frayed syndrome.
Oh, what is Frayed syndrome?
Sir, injury to the auriculotemporal nerve, leading to the regrowth of the
Auriculotemporal is branch of what?
mandibular branch of trigeminal nerve.
Yes.
Leading to regrowth of the postganglionic parasympathetic fibers into the sympathetic fibers, which leads to gustatory sweating.
To those parasympathetic fibers, they get.
Yes, sir.
What
When
happens
this
to
is
the
when this is
parasympathetic fibers of the
regenerative,
organ?
while getting regenerated, instead of supplying the parotid is not there now. So it supplies the overlying skin now as it regenerates. If this now get attached to the sympathetic of the skin, what is the function of sympathetic on the skin? What is the effect of sympathetic stimulation on the skin?
It will increase.
How do you describe? How do you describe? It is pseudomotor, pilomotor, and secretomotor. If you talk of the sympathetic supply to the skin, it's a pilomotor, means if there is a hair follicle, that can get erected. Secretomotor means it stimulates the sweat glands. And vasomotor means it causes vasoconstriction.
So, means suppose in Frayed syndrome, what will happen? What will the patient complain of?
Gustatory sweating. So there will be drooling of saliva.
Drooling of saliva is different.
Drooling of saliva. Drooling of saliva is something else. That will occur during, if you have injured the facial.
Yes.
But
there will be there will be sweating when during mastication.
Patient may have burning pain also.
Burning pain.
Patient may have burning pain, sweating.
Now, can these nerves get innervated to something else? Means you have said about the auriculotemporal nerve getting innervated into the sweat glands, right? Can it get innervated somewhere else? Can it go and get, suppose it goes and gets attached to the lacrimal gland, then
there will be
crocodile tears, right? So while eating, you'll find that the patient is crying also. Normally we cry when we eat those bitter things, isn't it? So here the patient will start. How do you, now how do you identify, means there can be sweat normal, it can be a normal sweating also. How do you identify this? How do you say that, yes, it is due to Frayed syndrome?
It will move during mastication.
Okay, mastication, okay, sometimes when I eat also, I also sweat. So, but how can you label that yes, it is due to this thing itself? Can you do some tests?
Iodine starch.
Starch iodine test, very good. So, starch iodine test is one test. If you paint that area, then it will become brown. That is also, the other name of that test is minor test, right? So how can you, that is what I was telling, you can prevent that by placing a flap between the skin and the incision, means the operative area. That is one option by which you can prevent this.
That is an optional because routinely you don't do it. Okay.
How do you treat this?
Treatment.
If I ask you what is the gold standard treatment?
Usually, sir, we go for wait and watch policy. It is spontaneous resolution occurs in most of the cases.
What else you can do?
We can, sir, hyoscine. We can anticholinergic. We can.
It can be a local application anticholinergic. And another important indication now is
Botulinum
injecting.
Botulinum toxin injection.
Same botulinum toxin acts as an anticoagulator. It prevents the release of acetylcholine, right? So the botulinum toxin is the gold standard treatment. Okay, what other complications can occur?
Parotid fistula.
Parotid fistula can occur. Very good. So what do you do with that? How do you treat that parotid fistula?
Usually, mostly, sir,
How can you
spontaneous
reduce salivary secretion? How can you reduce salivary secretion?
anticholinergics,
Yes.
hyoscine.
So you can use that also.
Yes.
You can use compression dressing also. Here also botulinum toxin acts. But if all these measures fail, then you need to do
Tympanic
a
injectum.
completion parotidectomy. Then only this fistula will subside. Okay, one last question.
Yes.
This is a gold medal question. What is first bite syndrome? Have you heard the name of this complication? First bite syndrome. It is a unique complication of this superficial or any parotid surgery. What happens while doing parotidectomy, if there is loss of innervation of the sympathetic supply, then what happens? There is overstimulation of the parasympathetic supply. So what happens during the first bite, there is spasm of the myoepithelial cells. But as you continue eating, then what happens is slowly and slowly it subsides. So this is a very unique complication. I have seen only one case till now. Means I did not know it also. The patient was I was just ignoring the thing. Then I felt then it was a severe issue. Then I started reading and then I came across this. This is known as first bite syndrome, and the only treatment is you can assure, or some people say, means I had referred the patient somewhere and then I found out they gave carbamazepine. So carbamazepine actually, then it relieved the symptoms. So this is one unique complication. I think
Okay, yes.
that is
Yes, we have discussed that. You see, your exam is for maximum 5 to 7 minutes. So basically, you should be very clear about few things like indications, then preparation, particularly for patient who are doing special position. You should be able to decide the position, and then incision, and then next steps. You have hardly 7 to 10 minutes maximum for your exam. We have discussed 1 hour. Okay. Thank you, Dr. Dey. Thank you very much.
Thank you.
Yes.